this healthcare panel speaking because
whatever that field is, which we'll discuss here in a little bit. But this is an informational session, not only for you guys, but for me too. So her studies at University of Nebraska Medical Center, she's dedicated to bridging the gap between oral and systematic health in our communities. Please help me welcome in Vicky. Here next to her, we have Fatima Hassan. She's a distinguished mental health professional with dual degrees in clinical social work and public health from UNO and UNMC. Originally from Somalia and Kenya, she is driven by her belief that mental health is just as important as physical health. So welcoming and helping me welcome her. Right next to her, we have Dr. Ali, originally from Niger and based in Omaha. He is a dedicated primary care provider specialized in family medicine at Miracle Primary Center. Welcome, Dr. Ali. Right next to her, we have the beautiful Dr. Che. She's a medical doctor specializing in child, adolescent, and adult psychiatry. She's dedicated to empowering children and adults through nurturing and supporting kids in various stages of their life. Welcome, Dr. Che. Next to her, we have here in Omaha for the past 13 years. She's currently pursuing her Doctor's of Nursing Practitioner degree in family practice at Nebraska Methodist College, and she's set to graduate this July. And last but not least, we have Captain Joel. Captain Joel is a physician assistant in cardiology from Kinshasa, Congo. After graduating, Captain Joel attended PA school in Pittsburgh, and since he has gained extensive experience working with the cardiothoracic and vascular department for 9 years. He also serves as the captain at the AMEDD department of the National Guard of Nebraska. Welcome. Now I would like to acknowledge people who have helped us into bringing this event forward. So if you are a part of organizing the event, I would like you to stand up and be acknowledged by the people here.
My name is Mohammed Mahal. I'm founder of East African Development Association of Nebraska. It's a local non-profit. So the mission is supporting refugees from that area. And I'm very happy being here today, and thanks so much, everybody.
My name is Anissa, and I'm the president and founder of Fearless People's Organization. It's based in Omaha. Our work encompasses helping those that are in need, so disability, those that are orphan. We do a lot of work back in Africa mainly, and we're trying to do some programs here in Omaha as well.
Hello, my name is Dr. Hani Chauri Mondiba, and I'm the president of the Association of Burkinabe in Nebraska.
My name is Sonia, and I'm the executive director of Family Sport Foundation. We help children here and also in Benin, West Africa. We partner with NGOs to be able to support the African immigrant family, and also we work with the moms, with the heart transplant moms to Children's Hospital. Thank you.
Hello everyone, my name is Judith Obudugo. I am the president and executive director for Callisto's Multiple Myeloma Foundation, where we advocate for families that have multiple myeloma cancer by creating awareness and connecting them to resources that they need in the community, and also for medical research and opportunities. Thank you for having us here.
Hello everyone, my name is Sylvester. I represent the Nebraska community. We organize, we come together, we assist, especially African communities here and back home. We try to help them integrate and provide assistance wherever we can, especially with the students that migrate here from us. Thank you.
Both of them. I'll add a few things in the realm of families, and when it comes to kids, the cultural competence is not just the provider understanding the patient, it's us as immigrants or even just allies of immigrants understanding this culture. And so let me give you an example. Most of us know what gari, eba, fufu, couscous, all of those things are, correct? Well, show of hands if none of this sounds correct to you. Just want to make sure. Okay, back in most African countries, when we eat those foods, right, we walk to the market. We walk to our auntie's house, we walk somewhere. We actually walk to go buy the gari or whatever, and maybe get in the car and then go home. So you eat all these things and then you walk somewhere. Here, most of us drove here. None of us, not unless you live in the dorms, did not walk here. And so part of knowing the culture is that the same things that we did back home, and they were okay. Those calorie-rich foods, for example, culturally beautiful foods were okay. but the amount that we consume here might not work for this culture and might lead to more disease and predispose us to more disease than we were used to. So therefore, when we have symptoms like the ones that my colleague was about to explain to us, we might not even know what they are. We're not even used to the fact that we get sick. We're just never sick when we were back home, or our parents were never sick. Anybody we know just didn't go through that. And then we start to wonder, well, what's going on? Maybe the provider is not taking me seriously, or the system was not paying attention. Partly is because back in our culture, we ate a certain way, we ate certain foods, we did certain activities that just helped us stay healthy. Here we're very sedentary in general. If you don't get up and go to the gym, it's just not gonna happen. Like even for me, I'm sitting there like, what? I exercise this time, and I just sniff food, and it feels like I've gained 10 pounds. And it's very annoying. And so as a culture, we're not, back home there's not a bunch of, oh, let's go to yoga, jog, and no, you just walk around and you just stay fit. You go to the farm or whatever, even if you were in a bougie, not going to the farmhouse, you were staying fit somehow. You go play with the neighborhood kids, you go to somewhere, you're walking somewhere, you're doing something. Here, by nature of the culture, so you sensitizing yourself to the difference in cultural landscape can't even keep you healthy enough to know what it is. So when you show up at my office, somebody else's office, and you're not even making that eye contact, maybe they look at it as, oh, maybe it's a cultural thing, but for you, you're sitting there like, I'm so down right now, I don't even know what to say. Partly it's a cultural thing where, hey, in this culture, looking people in the eye is not a bad thing. It's actually a sign of respect and you're paying attention. In different African cultures, how dare you look me in the eye, right? So learning the differences in this culture could be a life-saving thing, just like my colleague said here about that eye contact. Look your provider in the eye, help be confident, say, speak out loud. Back home, the thing was, don't look me in the eye. You're being naughty, you're being bad, how dare you? Or females, males, don't look each other in the eye, whatever. Learning this culture is very important for your health. It's not just a getting along thing, it's a matter of survival. It's a matter of like, this could mean you're depressed, versus this could mean it's my culture, I don't look you in the eye. I could read that as, oh, it's your culture and you don't look me in the eye, versus, oh, that's a sign of depression. The way you're acting today is different. So that's one of the things I wish to tell you is also learn this culture, learn the difference in landscape, sedentary versus ready, passive, active, or not, depending on how things were back home for you and your family, or if you're born here.
Which means destruction of muscular cells, which can be deadly because it can attack your kidney and cause kidney failure. A lot of situations of kidney failure we see is due to medication in this country, because for everything and anything is medication. Unfortunately, or fortunately, a lot of conditions do not need medication. They need education, they need effort from the patient, and they need engagement between the patient and the physician. So, the probably last example I'm going to give is also during access to healthcare, we have to know exactly what is going to happen. A sad example that I've seen was I was doing my residency in labor to labor to have a baby, and the baby was coming through normal vaginal canal, and the physician was ready to do something called episiotomy. Episiotomy is cutting part of the vaginal tissue for the baby to be able to access easily and come out without any distress. Unfortunately, the husband being present in the room, he refused the physician to practice or to do episiotomy because it's just not acceptable for him. He doesn't want the thing to get bigger, which is lack of education, which is not understanding how the human tissue works in case of injury, and how the human body heals after birth. If this patient or if this husband knows, he did a little bit of homework, when he had asked the right question, he would not behave in that manner. Well, it has to be difficulties between the team and the husband. He has to be taken out the room. Unfortunately, before then, the baby has suffered, become blue, and lack oxygen just as a result. So education is extremely important. It helps us break the barrier, have the right way for our practitioner to access our culture, to access our mind, to access our culture, and understand what is okay, what is not okay, how they should intervene in order to make us better. Are predisposed to hypertension. So there is some genetic element to hypertension, but also hypertension can be secondary, meaning it can be due to certain health conditions, medication, stress, sedentarity, obesity, etc., etc. So I think as a Black descendant, we should be aware of what is normal reading for hypertension, for blood pressure, first of all, and what is considered high blood pressure. what does the top number means, what does the lower number means, and from what point we start talking about hypertension, and how many stages are there for hypertension, and what are the symptoms for hypertension. Because if I start having those symptoms, I'm more likely to tell my doctor that I'm, example, having throbbing around my eyes, I'm having headaches, I'm having lightheadedness, I'm having chest palpitations, and I feel warm all of a sudden, and then my temperature cools down, or when I go at night, I lay down, I get up, I almost faint. Signs like this and symptoms like that can be associated with hypertension. But without knowing, you're less likely to go and check. And the other thing also to note is there are conditions, there are medications that can cause hypertension, like I said. So knowing those also will help you to prevent and also to talk to your doctor to get a cause of hypertension. And it's also important to know that high blood pressure has complications. It can affect anything in your body. When I say anything, literally, I mean anything in your body. Starting from your brain, your oral health, your heart, your lungs, everything, your just genital organs, everything. So high blood pressure is extremely important. The most important thing about that is prevention.
Related to high blood pressure, there's also trauma and stress as well. And typically in African communities and populations, we tend to come from war-torn countries, which exposes us to a lot of trauma. A lot of trauma means a lot of cortisol in your body, which also means it contributes to your blood pressure as well, right? So we're talking about genetics and kind of like where you come from. That is also just another point I wanted to mention. Like trauma does impact your body and it takes a physical toll on your body as well.
And I was gonna add another thing, we're so used to night shifts. It's another piece that as a culture, again, going back to cultural competence, that was not a thing as much back home, unless you were a guard, like a guard for a gate, what we call gate man or something like that. Most of our parents, ancestors, families, siblings, ourselves, did not do night shift. But as a culture, for survival, for the pay difference, for different things, in general, it's so prevalent in every culture, not just an African thing, but I just know a lot of us do it too for the sake of our kids. Like my mom, in fact, maybe she's just sleeping now because she's come back from a shift. That's how she put me in medical school, was her night shifts got me to this point. And so I have empathy for that. I'm not saying I'm just saying let's be aware that's a physiologic change in your body that predisposes you to depression, anxiety, hypertension, cardiovascular disease. In fact, the WHO put it as one of the carcinogens. Shift work, night shift work. As a carcinogen, even when I heard, my mind was blown. So that's a big thing that in our communities, so prevalent in most communities, not just African, but I know for us, it's a matter of life and death. Like, I need to take my kids to school if I'm the only parent in America. I need to work night shifts so I can come back and take B to school, take A to school, and pay the bills. And those things, once we can get away from it, I encourage us to do so. Once you're privileged and life has given you the chance to step into the daylight, I know it gets comfortable and the pay is very astronomically different. I beg of you to consider. Once you're able to, and God willing, that becomes your case, please do so.
The different refugee services, populations, it's kind of, I think that we've come a long way since my family came to the United States about 20 years ago. There are a lot of resources out there. I think it's more about awareness of those resources and access to those resources, as well as having providers that look like the clientele, right? So for example, in my graduating class for my degree and my background in mental health, I think I was the only Black African Muslim woman that graduated, right, with a clinical background, correct? But there's such a high need for Black African Muslim women needing mental health services. Does that make sense? So the provider isn't there, but the clientele is there. So it's more about what barriers can we remove to make sure that we have those providers put in place so we can serve the population that is there. Because the need is there, it's the providers aren't there, right? What can we do to incentivize these providers and stuff like that? That's one way I'll answer it. I don't want to take up too much space, I'll give it to the rest of my colleagues to answer.
I don't have a specific website or thing in mind, so if someone has it, please put up your hand and share. I work in council laws primarily, even though I also work in Nebraska, so I don't have a Nebraska-centric website. But the biggest thing I'll say, more than the resources even, is not just the awareness, but the change in mindset. Going back to that cultural piece, again, in my culture, there was not a word for psychiatry. I didn't even know what that meant. There was not a word for mental health that I knew of. I didn't even know what that meant till I got here and in medical school discovered that, oh my goodness, this is what I really like. And so in most homes, our problem is not that, oh my gosh, we need help and we don't know where to go. It's the fact that we're in denial. I'll use this opportunity, a public service awareness announcement on trauma. One of us here knows somebody who was either molested, abused, or any of those degree of things in childhood, but the family has told them, oh, how dare you talk about auntie or uncle like that? Don't bring it up. Stop. Just grow up. You're here now. It's past. What happened, moving on. And this kid grows up and shoves it down and just drinks or just does all this other bad stuff that we can't understand, or does really well, but struggles in a very silent way, and it's just okay with the family because, you know, we're Africans and we don't have issues. It's just those other cultures that have issues. There's a lot of that. So most of the times the problem I see is not like, oh my gosh, my child needs help, can I come see you? It's like, Dr. Chair, this thing happened, but like, how can I keep it like not from showing up? I don't want them to label my child, you know, that's an American thing, that's so that not us, it doesn't happen in our household. And I want us as Africans to know, American, white, whatever you are, we are human, and because we're human, trauma happens. Bad things happen, depression happens, epigenetic, situational, whatever. Acknowledging it is where I think as an African culture, we're falling short, especially when it comes to trauma. 1 in 10 kids will be sexually assaulted. 90% of their assault happens by somebody they know. That for me is the thing that if you don't remember anything today, please keep that sobering statistics in your mind. As I'm saying it, I'm even having chills. I see that a lot, where we just don't acknowledge the pain that happened. The kid shows up here. When America, forget about it, we're not being labeled. So I don't even see a problem of finding resources. I see a problem of acknowledging that depression is real. Part of it is environmental, there's a thing, there's organic, and there's weird spiritual stuff that just happens that we don't know. As a culture, that's something that we're used to a little bit more than the American culture, is that spiritual engagement. We believe that witchcraft is real, or most people, because you've seen the weird thing back in your village, or an auntie and uncle, and you're like, this is real. If we know that that's real, engaging that, just because we're American, that doesn't go away. If that person is having weird spiritual attacks, don't say this is America, it's fine. Figure out what in your culture makes sense to as an engagement treatment. Spiritual, church, what have you. If the kid is saying I'm depressed or acting out, don't just say it's an American thing, let's whoop it out of you, or stop it, or send you back to Africa and you'll be fine. Figure out what is going on. That is more what I want to impress on you. But
African American, most black people are predisposed to have high blood pressure, and that's we have seen that the majority of the time. And the best way we can actually start combat that starts with a daily check high blood pressure. We just don't know it, or more. And we will only know it when we'll start having symptoms, or when things start getting worse, or when you just go by mistake you went to the doctor because you were hurting here, and then when they check your blood pressure, oh, your blood pressure's fine. And you're like, I've been always fine. Or when you're in Congo, or when you're back at home, you'll see someone die. Oh, he has been always fine. Well, we don't know. He probably had high blood pressure, or he had anything that could have caused this. Oh, he had kidney problem. Oh, he has this now, this. And the blood pressure was probably the cause of it, and we were not aware of it. So since we're here, what I can probably advise each and every one of us is we need to start, me including, us included also, because we're the bad patient. Because we need to start every year, start checking our blood pressure, go for a yearly checkup, and that's how we can actually start preventing some issue like blood pressure and all that. So
oral hygiene. Some of us may be at the beginning, some of us may have more advanced disease, and with that, we just don't know unless we go and get it checked out. So a lot of times in the dental office, I graduated last year, so I've only worked a year, but when I do see African patients or Black African patients, I see that they are more in advanced disease because they have not been to the dentist maybe the entire time they've been in the United States. They could be in the United States for 10 years, 15 years. They're only going to come into the dental office when something hurts. And I just want to emphasize that you don't have to go to the dentist when something hurts. You can come and see us or see anybody before that. Prevention is always the best. You always want to prevent disease before it happens. And so with periodontal disease and getting your hygiene situated, we always recommend that you brush. So I know back home, we may use sticks. Is everybody familiar with those? Yeah, with the sticks. And so I've been home twice. I went to Uganda twice, and this one, yeah, with the trees. Yeah, you get off the trees. Yes. And so I've tried those too. And so being in the United States, I've been in the United States for 20 years, and I've seen there is definitely a difference with what we use here versus what we use at home. And so kind of learning, okay, what can I do here? Because we have more resources here for dental health. We have more resources to, you know, step up and be more preventative versus restorative. And so making sure that we're using the right tools, making sure that we're getting the right products that have the right ingredients for the specific problems that we have or the problems that we need is really, really important.